Good evening, everyone. My name is Lynn Flanagan and I am a Quality Improvement Manager in the Health and Social Care Improvement Team in the Care Inspectorate, and I'm absolutely delighted to welcome you to session 2 of the potty learning events, and great to see so many of you saying hello in the chat. This session is a follow-up session from the one that was held in November, and in the ethos of You Said We Did, this will cover some of the topics that you highlighted you would like to know more about. You're in for an absolute treat tonight because we are joined by Juliet Rayner, who's the CEO of Eric Children's Charity, and Suni Liston, who's Eric's paediatric nurse. We're also joined tonight by Jenny Ross, who is our Improvement Support Officer, who's looking after the slide deck and everything technical. And we're also joined by Jackie Dennis, who's our Senior Improvement Advisor, who will be monitoring the chat to pull together all of the questions for the Q&A. Next slide, please, Jenny. So your microphones and your cameras will be off for tonight's session, and that's just to ensure the smooth running of the session, just because we're expecting so many people to join us tonight. The session is being recorded, so by taking part, you're consenting to that, and the recording and the slides will be sent out in a few days' time. Please do put your questions and comments into the chat, and we'll be able to pick up your questions as part of a Q&A session later on in the session. We want tonight to be interactive, so we are going to be using the chat, but also we'll be using polls. So Jenny will be putting some polls up onto the screen. Sometimes it takes a wee second for it to pop up onto your screen, but if you don't get access, sometimes access to polls can be affected by your pop-up status. So if you find it's not working for you, please do put your answer into the chat. If you're having any sound issues tonight, please do make sure you've got the volume turned up on your device. And this is your session, so please, we want it to be interactive, we want it to be informal, so please do chat to each other in the chat. Please do we pose us questions and also participate in the polls. Next slide, please, Jenny. So these are the aims of tonight's session. So we will be highlighting Eric's new potty training online course and highlighting Eric's potty training champions programme. We will be exploring how the role of parents in all of this and how we can make sure that we've got the right kind of resources available for parents. We'll be highlighting good practice and information, and also we'll be introducing Eric's nurse, Suni, who will highlight what's happening across Scotland to support potty learning and bowel and bladder health in children. And then it will be over to you, so there will be an opportunity for a Q&A session later on in the session. So without further ado, I will hand you over to Juliet and Suni. Juliet Rayner joined Eric as CEO in May 2015. With the team, she's established a clear vision and strategic direction, raising awareness of the devastating impact that bladder and bowel conditions can have on children, young people and their families. During Juliet's tenure, Eric has become increasingly internationally recognised as a responsible and ambitious organisation, maintaining the needs of children, young people and families at the heart of their decision making. And she's joined by Suni. Suni recently joined Eric in the position of Eric nurse. Suni has worked as a paediatric nurse, paediatric urology nurse specialist and a health visitor. And Suni is a committee member of the Paediatric Continence Scotland group and is based in the Highlands of Scotland. So without further ado, let me pass you over to Juliet and Suni. Welcome both.
Hello, and thank you, Lynn. Wow, I can't believe it was last November that I was here talking to you all 6 months ago. It feels like yesterday. Fortunately, we've done a few things since then. So hopefully, for those of you who were here last time, this isn't going to be too repetitive. Hopefully, we've moved on sufficiently for you to think it's worthwhile us coming again. And for anybody who wasn't here last time, I do understand from Jackie that she has got the slides and everything from last time, which can be shared with you. But that said, if you've got any questions as we go along, because I'm racing through it too quickly, or Sunny is, then please feel free to ask us as we go. So Jenny, next slide, please. So we've had kind of the aims of the session, but just to say from my perspective and Suna's perspective, we will do a very, very brief recap on ERIC and what we do as a charity. We'll talk a bit about why children are being potty trained later, and go into much more detail this time on the Bristol demonstration project. So that's our partnership with Bristol City Council. And then I'll then hand over to Suni, who will talk to you about the role of health visitors in Scotland, and the health visiting pathway in Scotland, as well as a bit about paediatric continence Scotland, and then share with you a really good case study. Next slide, please. So those of you who were here before, you will have seen this. It's only 1.5 minutes long, but I thought for anybody new to it, at least it gives you a chance to know much more broadly what ERIC is involved in, aside from just the potty training. So I think Jen is going to show the slide now. Here we go.
1 in 12 children in the UK are affected by a bowel or bladder condition, including constipation and soiling, wetting accidents, and bedwetting. The impact on children and their families' lives can be devastating. For more than 30 years, ERIC, the Children's Bowel and Bladder Charity, has been dedicated to improving these children's lives and reducing stigma around these conditions. Our award-winning work is recognised in the UK and internationally. Our free helpline supports over 3,000 families each year with one-to-one advice and support. Our website is packed with clinically approved information and resources, including potty training, treating constipation, using the toilet at school, and supporting children with additional needs. We are the go-to training provider for the NHS on paediatric continence. The ERIC online shop stocks bedwetting alarms, clothing, books, and bedding. As a charity, donations and profits we make are all invested back into our free services for families. So that's ERIC. As you can tell, we are passionate about childhood continence. After all, wee and poo is what we do.
So there you are. That's just a very brief overview of what we do. And if anybody happens to be at the Manchester Science Museum at the weekend, you'll be able to meet Wee and Poo in person. There's a big exhibition on what happens to your poo, I think, as it goes through your body, and they're going to be there as the guests of honour. So could I have the next slide, please? So at ERIC, our vision is that children and young people everywhere enjoy good bladder and bowel health. And if anybody was here in November and memorised it, our vision has changed since then. So we've spent some time over the last few months in actually developing our new strategy for the next 3 years. And our vision was that children everywhere should be able to, children with a bladder or bowel condition should be able to live happy, healthy lives. And we still believe that, but actually we've now encompassed the fact that good bladder and bowel health is important for all children, not just a child that's actually got an underlying condition. And even more so, we believe that this should start from birth. So everything around prevention, early intervention is kind of tied into everything we do right from the very beginning. Can we have slide 5, please? So we talk about good bladder and bowel health for all children, and it does start from birth. And obviously potty training is the first milestone really we think about generally with children in terms of becoming clean and dry. Well, it's all gone a bit wrong, hasn't it, really, if you look at that. So 60 years ago, 97% of parents were helping their child to use a potty from when they could sit up. Probably a good reason for that is that children were in terry nappies, and it was a big job to keep the nappies clean, and the smell wasn't great of the product used to clean the nappies. And I've heard anecdotally that for many parents, they wanted baby number 1 to be out of nappies before baby number 2 came along. And when baby number 3 came along, baby number 2 had to be out of nappies. You can imagine how awful it would have been if you had sort of 2 or 3 children all in terry nappies at the same time. And then with the kind of onset of disposable nappies, by the 70s and 80s, most children were out of nappies by the age of 18 months. So as you can see, we've already moved up quite significantly. 70s and 80s, that was kind of 50 odd years ago, wasn't it? So it did move up quite quickly. And then by 2004, the average age that a child was potty trained in the UK was 2.5 years old. And again, we contribute that quite largely to disposable nappies, in that the quality became better and children didn't feel so wet, and they wouldn't have shown those, so say, telltale signs that they needed their nappy changed. And just 20 years later, in 2024, worryingly, the average age of potty training has now risen to 3.5 years, with more children than ever starting school in nappies. So to jump up a year in just 20 years is actually a very worrying statistic. Can we have the next slide, please? So the first of our polls this evening. Firstly, I'd be interested to know how many nappies do you think go to landfill every year in the UK? 100 million, 500 million, or 3 billion? I think we get to see the results of that, don't we, Jenny, before we move on to the next question?
Yes, it should just appear on your screen
Right,
there.
okay. So I think, oh, we're moving again. Can everybody see that on their screens, that it's moving backwards and forwards?
Yes, I can see that.
Yeah. Okay, well, there's quite a big difference, isn't there, between 500 million and 3 billion nappies. And 48% of you were absolutely correct. There are approximately 3 billion nappies going to landfill in the UK every year. It's quite shocking, isn't it? And just to add to that, that equates to about 400,000 tonnes of waste caused every year. Single-use nappies account for between 2 and 3% of all household waste. And nappies take over 300 years to decompose. So even if we weren't interested in bladder and bowel health, and even if we weren't interested in children being ready to start school, ready to learn, you'd think that the environmental impact of disposable nappies would be a good enough reason just on its own, wouldn't you, to actually think about training children earlier? Okay, thank you for that. So the next question is, what is the estimated number of single-use nappies that a child potty trained aged 3.5 years will go through before they're toilet trained? Or 8,000's creeping up there. Neck and neck, 13,000. It's actually closer to 8,000, believe it or not. Automatically thought was going to be the 13,000. Oh, I think I've said too early because people are still responding. Now we've got more people saying 8,000. Oh well. Yeah, so about 8,000 nappies are used on every child. That's during the course of the day. So I guess with it's assuming nighttime dryness is younger than that. So actually, if you looked at dry nighttime as well, I counted those in, it would be close to the 13. And again, if you look at nappies and how much they actually cost, based on a child being trained at 3.5, that's going to cost a family about £1,500 a year in total. Sorry, in total. And then if you add on to that nappy sacks and wet wipes and all sorts, it's quite an expensive business actually keeping a child in nappies until they're 3.5. Okay, next slide, please. So just to kind of emphasise where we are with toilet training, I don't know if you've heard of the School Readiness Survey. It's a charitable foundation called Kindred Squared, run a school readiness survey every year. And they do the survey in September and the results come out in February the following year. So this is the latest one, and it covers England and Wales. And as part of their study, they interview 1,000 teachers and about 1,000 parents and carers, and that's a combination of survey and focus groups, and they cover all sorts of school readiness issues. I can put the link in the chat if people are interested, because it talks about a whole range of things, but they look at potty training or toilet training, and as you'll see there, 90% of school staff reported that at least one child started their reception, or I guess in your case, is it primary 1 class, not toilet trained. 1 in 4, 25% of children starting school in nappies, and 50% of parents think it's their responsibility to train their child. The other 50% don't see it as their sole responsibility. They see it as partly their responsibility and partly responsibility of others. And I'm guessing that that includes you, people like you. Yes, it is quite a shock, isn't it? That's where we are. That's what parents think. So it doesn't seem to be the top of the list. And interestingly, when this report came out, there was quite a lot of publicity around it, lots of press release, press articles. And, you know, as I said, it covers all of the different school readiness issues, like holding a knife and fork, being able to dress yourself, being able to sit still. And yet it's the toilet training statistics that hit the headlines. And it just seems quite ironic that everybody seems to think this is just one of those things that should happen. And it's a shock when it doesn't. And it's more of a shock that a child isn't toilet trained, according to the headlines, than it is for a child not to be able to speak properly when they start school. And yet actually in the learning and the education and the encouragement, toilet training doesn't even really figure. So it just feels like quite a distortion of facts and the kind of support that we're giving. Can I have the next slide, please, Jenny? So why are children being toilet trained later? Well, back in 2019, Eric ran a survey with the National Day Nursery Association, and we also gathered feedback from families and healthcare professionals that we speak to as part of our day-to-day work, and some of these are anecdotal and some of them are from surveys. And we've talked already about the introduction of disposable nappies and how absorbent they've become. I mean, I remember when my own children were in disposable nappies. This is going back, well, they're in their 30s now, and they really were awful things. You know, they would get so wet and they'd be so baggy, you would know that they needed changing. But now you just don't know. They're so absorbent and so light. It's very difficult to see that they need changing. Children don't seem to be uncomfortable. They don't get nappy rash. And so this is kind of one of the main reasons why children are being toilet trained later. And I could get more cynical about the advertising from some of the big companies around disposable nappies and some of the introduction of other pull-up pants and things like that that are all based on disposable nappies. But other reasons that people feel there's been a delay is lack of clear guidelines. So lack of formal training and best practice for potty training, and links with good bladder and bowel health for early years practitioners and health visitors. So not really seeing the connection of potty training with any other general good bladder and bowel health, just seeing it as a kind of one of those milestones that you need to get through. And with little guidance on how the kind of the best age to do it, the best way to do it, it just seems to just get left, or all sorts of different things happen. Another big reason, and I'm sure you would have seen this in your settings, changes in parenting style. So modern parenting theories emphasise a child-led approach, and often they'll wait for signs of readiness. And we know now that signs of readiness are a myth. You know, there aren't signs really. A child isn't going to put their hand up one day and say, "Mummy, it's time for me to use the toilet. Please, can you teach me?" So if a parent's waiting for a sign, they may be waiting far too long, or they may never get the signs at all. Changes to family life are a big issue. So, back in the day when we were looking at the figures earlier, sort of 60 years ago, and even in the 70s, it was very likely that both parents in the household weren't working, mum maybe staying at home and looking after the children. And now we've got both parents in the household working. Many children are spending longer in childcare than they were before. But it's not just that. It's more children are living in single parent households, spending time between mum and dad, and they may have different styles. Children spending time with other family members, with grandparents, and routines just aren't what they were back 60 years ago. There's much more going on, everybody's in a hurry, and these types of things don't work very well unless you've got a really good routine. And the lastly on this list was reduction in NHS services. So I know Sun is going to tell you about health visiting in Scotland, but generally we find that health visitors, the numbers being cut, they're not necessarily commissioned to help with toileting, leaving families with fewer places to go for help. And these kind of things are often likely to delay toilet training. Next slide, please. So, which brings me on to talk to you about the Bristol demonstration project and what we're trying to do to counterbalance what's been going on at Eric. Sorry, not counterbalance what's been going on at Eric. What we're trying to do at Eric to counterbalance what has been happening over the last 60 years until where we are now. So I did mention for those of you here that we were developing the Let's Go Potty online learning for early years practitioners, and I'm pleased to say that we've made quite a lot of progress since then. So can we move to the next slide, please? So I may have said to you before, well, I did say before, that we were developing 4 scripts at that point to cover potty training, so that we'd have 4 short videos, not taking longer than an hour in total, that early years practitioners could do in their own time or in their lunch breaks or even during the course of the day if it was permissible in that session. So I'm just going to give you an idea. We haven't finished recording these yet, but I'm just giving you a very short snippet from video 1, just so that you can see the style and the type of language we plan to use. So here goes.
What changes do you expect to the baby's wee and or poo? How do you ensure bladder and bowel health? Bladder first again. All you're looking for is several wet nappies every day. If the child's nappy stays dry for more than a couple of hours, have a look at what they're drinking. Might they be dehydrated? Then the bowel. You want to see at least 1 soft poo every day, an absolute minimum of every other day. The poo should never be hard. Have a look at the Eric poo checker. Does it resemble the soft, smooth sausage shown by type 4? Younger children's poo is often softer and mushier because their guts are moving more quickly. Type 5 or 6 can be normal. When first weaned, it is normal for a baby's poo to contain undigested food. Their digestive system is not used to dealing with anything other than breast or formula milk. If it persists over time, though, their parents should seek help from a healthcare professional. Don't forget that some foods, like sweet corn and grapes, can often be seen in poo, even in adults. And it's normal for foods like spinach and beetroot to colour the poo. Let's think about drinks. Develop a routine, a drink with each meal and a drink midway between meals. When a child is first weaned, they will still be having some breast or formula milk. But when that reduces, you can think of their fluid intake in terms of how many cups of drink they should have each day. Children of all ages need a minimum of 6 to 8 cups of drink a day, of a suitable cup size for the child. So for a 2-year-old, that would be 120 to 150 mils. In hot weather, or if the child is running around a lot, they need to drink more. Think about how long the child spends in your setting. Are they getting enough to drink? Think about how full you fill their cup to avoid spillages. If it's only half full, that's a minimum of 12 half cups of drink a day. How much of that should they be having with you? How do you monitor bladder and bowel health in your setting? Do you start conversations about drinks, wees and poos when the child joins the setting? Have a look at the potty training policy template on the Eric website and at the simple form, the Early Years Healthy Bladder and Bowel Assessment. Do you communicate with parents on a daily basis, noting fluid intake and wee and poo past? Good communication is essential for promoting bladder and bowel health, and a healthy bladder and bowel is essential for successful acquisition of bladder and bowel control.
Thank you, Jenny. So, as I said, that was just a snippet. The background will be different. The animations will be slightly different. And I don't know if it's a technical difficulty there, but I just saw Brenda's lips weren't moving quite in time with the speaking. But I wanted to show you that just to give you an indication of what we're working towards. So our videos, we've got 4. Actually, next slide, please, Jenny. So we've got 4. So the one you saw the little snippet from then is step 1, which is all about preparation. So the video for that one is 17 minutes long. That's the longest one we've got. And it talks, it's broken down into sections. So the first bit is around promoting healthy bladders and bowels in the first 6 months and after weaning. And it's really, say, some of those things that Brenda was talking about, being able to recognise a healthy wee and a healthy poo. And that kind of thing, and some of the things to look out for. And then at sort of the 6 month time, introducing the potty. So some of the potty learning skills and time, looking for signs of readiness. There may be. Now, I did say about the myths of readiness. Generally speaking, there are, but sometimes with very small children, you can actually see from their face if they're straining for a poo. That often changes as they get older, but with a small child, you tend to be looking at them more anyway. So you may notice, about 6 months-ish if they're straining for a poo or something like that. But it's this whole video, the first one, is all about the preparations stage. So talking about from when they can sit up, sitting them on the toilet, on the potty for a little bit, even if they're fully clothed, just sitting there reading a book to get them used to it. So do the whole 17 minutes, and then at the end of the video, there's about 5 multiple choice questions, and that's for the practitioners to complete. And once you've completed those questions, and there's no trick questions, everything that you need for the questions are in the scripts of the videos. Once you've completed that, so this is online, you click the answers, click done, and then you'll get an email back to say, congratulations, you've passed. Hopefully you'll get congratulations passed. Would you like to go on to video 2? So Jenny, if you'd like to move on a slide, please. So then video 2 is shorter, 9 minutes long, and this is about practicing. So it's reminding that potty training isn't an event, it's a process. It will take time. It does need to be calm and reassuring. There's no point tackling it with tensions running high and frustrations from the child or the parent or the practitioner. Everyone needs to be sort of calm. And it's about developing the skills, growing awareness of the body. And some of this may feel or sound a little bit repetitive from the first one, because it's actually quite difficult to stop and start, the process, and particularly as you'll have children come into the settings at slightly different ages. So there is a little bit of overlap, which is why it's much shorter, this one. So again, it would be Brenda speaking with a series of animations and charts and all sorts of things to show. And then when you get to the end of this one, again, there'll be about 5 self-assessment multiple choice questions. So complete the questions, submit, hopefully get them all right, and you'll say, I'll have an email say, congratulations, you've passed module 2. Please click here to go on to module 3. So if we can go on to the next slide, please. And this is the big one. This is where you've done all of the calm, reassurance. The child's aware of their body, they're aware of when they want to have a wee and a poo, all of those things. They're used to the potty, they feel comfortable with the potty, and you're ready to go. And the idea is, in this 15-minute video, it's all about taking the nappy off and ideally not putting the nappy back on. So we are talking here about daytime potty training. We're not talking about nighttime training at all here, but all about nap times, what you do about nap times, managing accidents, what you do when you're going out and about, how you keep records, troubleshooting, and then just a summary. And again, a series of questions, multiple choice questions at the end. Do the questions, then hopefully you get them all right, and you get a video to say, congratulations. You may want to stop here, but you can go on to number 4. So Jenny, could you go on to number 4, please? So this is the extra video, which is around children with additional needs. And some of this may seem repetitive from the previous 3, because actually quite a lot of the skills and the processes around toilet training are no different for children with additional needs. But you may be doing extra things. So the child might be a little bit older. It might be that they've got fears and phobias. It might be that you need to be taking account of their sensory needs, anxiety avoidance. And actually it gives you information of extra help that there may be available for children with additional needs as well. So this video is 16 minutes long. And again, there's a section with questions on there. And then at the end of this one, you'll get the next, if you put the next slide up, please, Jenny. You'll get this one that says, thank you, you've successfully completed the Let's Go Potty course. And then you put in your name and email address, press submit, and then you have your own personalised certificate. It's built for you. And then you've got your certificate to say that you've actually successfully completed the potty training course. And that's it. And those minutes don't add up to more than an hour. So hopefully that all sounds quite reasonable. Can I have the next slide, please? Because I can't remember what I'm going to say next. Oh, right, okay. So yeah, so that is it really in terms of the online potty training that we've spoken to you about. So I would really like to know now what you think about that. It's not finished, so it's with the videographer again. And as I said before, there'll be more animations joined, better backdrop, all of that kind of thing. But it's not too late for us to add anything or do anything slightly differently. So first of all, perhaps I could ask you to complete the poll. So first of all, would you undertake this training? Yes, no, or not sure? Great. Well, I'm glad nobody said no yet. I'd be really interested in the chat if anybody who's not sure explains why they're not sure. We'd be interested to know is whether you feel you know this already, or that you're not perhaps working directly with families that you wouldn't, or because you know something better. If you've got a reason for not sure, it would be great if you don't mind putting that in the chat. Okay, maybe they'll come up. Ah, poll's not working for some. Okay, in my chat, yeah, we can talk about other things afterwards in terms of posters and resources. It'd just be good to know why people would not be sure about doing the training, if anyone's got a reason for not. Okay, well, we will go on to the next question. So what we're also interested to know is we've designed this for early years practitioners in nursery settings and also for childminders. But we'd be really interested to know what we can do to make sure that parents and carers get the right information at the right time. And one of the things we're thinking about is whether or not we could design something very similar for parents that nursery staff could share with parents at the same time. So possibly everyone gets some very similar information at the same time or a similar time. So again, it'd be good to know if you think it would be a good idea. Well, there's no doubt there. Oh, from the people we've had so far. And lots of thumbs up, which I'm very happy about. Yes, we agree.
Can I quickly come in? Somebody's asking, can you explain what you mean by licensing?
Yeah, I will. And I'll come on to that in the next question. Somebody in the office asked that question today. So I will explain that before we go on to that question. I'm quickly reading the chat as we're going along, but it's moving too quickly. I don't want to start answering individual ones right now. But yes, I agree that something along these lines would be great for health visitors as well. But what we would need is to get agreement from the NHS Trust that they would be committed to training people, and that health visitors would be able to talk about this as part of their role, which is something that Suni will come on to talk about. Okay, right. So the last question here is, so as you know, Eric is a charity, and we've invested our own resources into actually doing this. So we've invested our time, and Bristol City Council have also invested their time. So as I mentioned last time, the scripts were written and shared with Bristol City Council, their 8 of their early year settings, and they commented on the language, the length, the way we describe things. So we feel relatively confident that we've got some of that stuff right. But we will need going forward to charge for it. So we can't just give this away to everybody. So we've done some research looking at different sites and different nursery umbrella organisations and looking at what people charge. So this is what we're thinking at the moment based on what we've seen, is that if an individual wants to buy one copy of the course, which is a single licence, so buy the course for one person to do a single use course, we were thinking of charging £15. So it'd be £15 for one person to actually go through those 4 modules and get the certificate at the end. But we're also thinking there may be individuals who want to do that. But if you're in a nursery setting, something like that, there may be a nursery that wants to each of their staff to actually do the training. And it may be they want to buy 10 copies, because it is one course for one person. So you might want to buy 10. If you want to buy 10, then we would think about maybe a discount of it being £12 per course or £12 per licence. So the cost would be £120 instead of £150 if they'd had to buy them all separately. And we've said between 10 and 99 copies. So it could be, if there's a big nursery chain, they may want to buy a lot. Or even, I know in Bristol, for example, they're planning, Bristol City Council are going to pay for it for all of their nurseries. So if it was more than 100 licenses, then we were thinking we could reduce the cost down to £10. So as I suppose, do you think that this sounds about right, or not? Do you think that settings would be able to pay this? Do you think it sounds a bit right? Or if you've got any other comments on it, then please again put those into the chat too. You know, if you think we're underselling ourselves, and we could be selling this with a nought on the end, so £150 for a single course, then please do tell us. It's always that sticky thing. We need to make it valuable and, you know, a valued resource. But we also need to make sure that it brings in a small income for Eric, because we will need to continue to update and change things and tweak things as we go along. But equally, we want it to be affordable for settings as well. So it seems that the majority, from the 74 responses we've had, the majority do seem to think it's about right. And some of you do think it's too expensive. So again, if anyone's got any thoughts on what the price should be, it would be interesting to know what you think. Okay, can we have the next slide, please? Well, that's it from me at the moment. The only other thing I wanted to mention was it was put on the initial slide, and I did talk about this last time, was the potty training champions. So we haven't focused on those for now. And we've had some feedback from different people. So you might remember I said before that the course is 1 hour, but actually you can learn so much more about healthy bladders and bowels, which we didn't think would be necessary for everybody in a setting to learn. But it might be that one setting wanted one person to be a champion, and they would perhaps go on a half-day training course to know things in more detail. Or a large chain might have 2 or 3 people in their central training department or something that had the more detailed. So you've got a go-to person if you've got ongoing problems. We haven't focused on that just yet. We wanted to get this done first, but some of the feedback we've had is that it's all very well training somebody and spending more on training a champion, but people do leave and they do move on. So actually the investment in somebody, because obviously it would cost a lot more if they came onto a half-day training course. So is investment in train the trainer a good thing or not? Or do you think that this is enough? So I haven't got a poll for this one. But again, it would be interesting in the chat to see if you think that having a sort of a go-to champion in your organisation, your setting, in your nursery chain that you could go to if you weren't sure what to do, then please, again, let us know. I just seen one comment there, which I think is really interesting about it being the same price for parents. What we were thinking was that it would be free for parents. So the nurseries could buy the package, which would include their training and the training for nurseries, so they could then release the training to the parents as and when they needed to. Okay. We've got the license being applicable to individuals and settings, because we are aware that some people are on their own. You know, if you're a childminder, you may be the only childminder, so you would only want to buy one copy. Or there may be somebody who's really interested in this and they're not maybe a designated person by their setting, but they still want to do it for their own CPD. And so they'd want to just buy one course so that they've got the training. You know, it might be they're looking to move on to a different nursery setting and they want this under their belt. So we would want to sell it as a one-off, but we do think the way to go is for the settings to buy as many versions of copies as they need to train as many people as they need. Yeah, we agree that we wouldn't want parents to pay. Okay, I'm going to stop because I know Suni has got things she'd like to say as well, but thank you very much for all the comments. I'll be able to look through the comments now in the chat, and I think Jackie, you'll probably be pulling some questions together. I don't know, did you want me to take the questions now, or do you want Suni to do her bit and we'll do questions at the end?
I think questions at the end while we're
Right,
on
that's
roll
fine.
here,
Yeah.
because there's a lot of nice things and it lets you then scan through.
Yeah,
You'll see the
okay.
kind of things I'm going to be asking.
Great stuff. Okay, well, Suni, it's over to you. Oh, I'll turn my camera off.
Hi, sorry, I'm just sorting out my camera. Thank you. Thanks very much. Well, firstly, I'd just like to say thank you for inviting me along. I've only recently joined ERIC, and it is a huge honour both to kind of work with ERIC and also to come along tonight and speak to you all. And it's really good to be able to provide a bit of information around practice in Scotland. So thank you very much to everyone. So I thought with my first slide here that, and I think it was upon request from yourselves at the previous session, which obviously I wasn't at, a little bit of talk about health visitors probably would be useful. Partly I am a health visitor, work in Scotland and have worked as a health visitor for several years. And also because we play such a big part in children's lives when they're young. I've been scanning the chat as we've been going along, and there's lots and lots and lots about health visitors there. So hopefully this will pick up and be relevant to you all. So firstly, just to start off, I was just going to say, you know, our aim from what Juliet's been discussing is that we want to promote bowel and bladder health from birth and to refocus the approach on how we toilet train children. So it's really important that we look at who would be involved in this and how we ensure they have the knowledge and the skills to do so. Health visitors are a really obvious group as we see children and families regularly from birth up until school age. The health visiting pathway is different in Scotland to other parts of the country, and so I thought it would be really useful to have a look at their role in a bit more detail to help people understand who plays a key role during early development, and that we all need to work together to make this work for our children and families. I'll also talk a little bit about the work of Paediatric Continence Scotland and go through a bit of a case study to highlight just how important it is to have input and support in this area and how it can really make a difference. So that's my plan. Hopefully you'll all bear with me as we go along. Can I have the next slide, please? So just a little bit about the background. It's a bit of a wordy slide, so I'll just kind of break it down a little bit for you. So there's a new health visiting pathway introduced in Scotland in 2016. We know, and the research showed that, as everybody knows now, the early years have a really profound impact on the individual's future experience of health and well-being. We've got loads of evidence which outlines the importance of kind of early intervention and prevention, and how important this is, not just in their early years, but actually throughout their lives. And we all know that health visitors have a really vital role to play in supporting families and children. We're in a really unique position when it comes to visiting children and their families in their own homes. So a scoping exercise by the government in 2013 looked at what was happening across the country and how there was kind of huge variation in services, and they changed the requirement for NHS boards to refocus this health visitor role, and that's when the universal health visiting pathway came in. It's actually just being re-evaluated just now, because unbelievably that's been around for 8 years, so they are looking at it again just now, but that's when it started, and it started integrating the named person role. So there was huge changes in the pathway, and it defines and enhances a health visitor's responsive way of working with parents and children. Next slide, please. So the aims of the pathway, this is what the pathway for health visitors is based on. So the idea being that we are promoting, supporting and safeguarding the well-being of children. It really places the person at the centre. They should build strong relationships from pregnancy, so even before the birth of the child, and offers most support during the early weeks and right through until they go to school, but very much during those early weeks. And you'll see that when I kind of put the pathway up later on, how it is focused on that first year. And it's very much a strengths-based approach. So GIRFIC in Scotland are getting it right for every child, really focuses is a strengths-based approach where we're looking for and trying to build on the positives while assessing and responding to the needs of children. Can I have the next slide, please? So I've just got a question for you here. When I spoke about the health visiting pathway, and I will put it up, I'm just wondering if I could ask you, from your own experience, or what would your guess be on how many home visits you think health visitors do as per the pathway? So this is for standard universal pathway, not for children who lie out with the pathway in that first year of life. Do you think it's 4, do you think it's 8, or do you think it's 11? I'm liking some of the comments in the chat. So I can see there's quite a variation. I can't see the overall poll results actually. Oh, it's maybe because I need to submit an answer myself. Then it'll maybe come up on my screen. So I can see, looking at the results now, that that most people have gone for 4. The actual answer is 8. So there are 11 visits as per the pathway throughout the child's life from birth to school, but 8 of those are within the first year. And I'll go on and talk about that a bit more, but it kind of, when there's a majority of people have gone for 4, that's really interesting to me, and I'll explain a little bit more about maybe why that seems to be the case as we go on to the next slide. But thank you, that's interesting reading. So what does the pathway involve? So it's a core home visiting programme to be offered to all families by health visitors as a minimum standard. So they are exercising the function of named person on behalf of the health board, and we are supposed to be available and responsive to parents and to promote and support the safeguard the well-being of children. And our role obviously is around about information, advice, support and access to other services. As I've just said, the programme consists of 11 home visits to all families, 8 within the first year of life and 3 child health reviews between 13 months and 4 to 5 years. The idea behind this being that these visits should all be at home, they should all be by the same person, and they should start before the baby is born. The idea being to build up kind of strong relationships with families so that there is that element of trust there that they will then communicate and be able, over all matters from small things to big things. And these visits should all be at home, because what we found previously when lots and lots of things, lots of health visitor contacts were in clinics, that there are a huge group of people who just will not attend for a variety of reasons, will not attend clinics. So that approach didn't really work. The people who you saw in clinics were the ones who probably didn't actually need that advice and support as much. So most people would respond better to home visits. So the idea being that all these visits are by the same person and also within the home environment is where the roots of the pathway are currently. So can we go on to the next slide, please? I wanted to show you what the pathway looks like, just because actually if you're saying 4 visits, then maybe hopefully it'll be interesting you to actually see it. So I'll talk you through it a little bit because it is a bit of a busy slide. So you can see it goes from pre-birth is the first contact, and then it goes with an antenatal contact to what we would call the new baby or the primary visit at 11 to 14 days, which is the handover from the midwife. And then there should be 2 visits between 3 and 5 weeks of age. There then should be one at 6 to 8 weeks of age, one at 3 months, one at 4 months, a contact at 6 months. It doesn't need to be a home visit, but it should be a contact and a review, and another home visit at 8 months, and then 3, as you can see, after a year, one at 13 to 15, 27 to 30, and 4 to 5 years, kind of prior to starting school. You can see there by the little key on the right hand side that you have the blue ones are child health reviews, and the little kind of star sun-shaped thing is data collection points. So those are kind of stored nationally. So that is what the pathway looks like. So there's certain documentation that is standard across the pathway. So we use what's called an ages and stages questionnaire. You've maybe heard of those. They're ASQs for short, and they're used alongside the visits, and they're just documentation that look at different aspects of a child's development. So things like communication, their gross motor skills, their fine motor skills. But really interestingly, the reason I'm kind of saying, talking about them is that actually none of these mention anything about bowel and bladder health at all in the ASQs until one at 60 months. So the 5-year ASQ actually mentions something about bowels and bladders. So I think that's really interesting that the guidance that health visitors receive actually doesn't point us towards bowels and bladders. Each area will have their local documentation as well. So it might be that in some places they do have some questions, their kind of care plans around about bowels and bladders, but the actual guidance from the government doesn't have that. It's like there's lots of positives of this pathway. It provides lots of opportunities for getting to know families and building relationships. It does and should ensure that children are regularly seen. And it does allow that opportunity for regular assessment, early identification, prevention and intervention. We should be able to pick things up early. We should be able to signpost, refer, support. If you look at this pathway on paper, it definitely ticks a lot of boxes. But when you place it in the context of kind of healthy bowels and bladders, there's quite a few challenges, and there are challenges associated with health visiting as well. So I'll just talk a little bit about those. Can I have the next slide, please? So this slide here just gives you one example. So this is the guidance that we would receive around about the 13 to 15 month review, and it's quite a difficult to read slide because I've taken it directly from the guidance. But the reason I wanted to show it to you is that as you can see here, there's absolutely no mention of bowel and bladder health. So if you're a health visitor and you're looking at child development, you're focusing on gross and fine motor skills, speech and language, social, emotional behaviour. You're looking at their physical activity, their nutrition, their growth, but actually there's not one mention there. They're looking at dental health, but nothing at all about bowels and bladders. And it's the same with the 27 to 30 month guidance. In fact, it's the same with all of it. And if nothing is mandated, then actually you're really relying on the individual. Some health visitors might talk about it, some might not. And that really comes down a lot to their own kind of personal experience and preferences, and also other time constraints, which I'll go into a little bit later. The other thing about the pathway is if you look at the distribution of the visits after 1 year, there's nothing from 13 to 15 months until 2.5 years or 27 months, and then nothing until 4.5 years. And if you're thinking about when the majority of people are toilet training, then actually there's really very little support and contact during that time. And if you go in, what we would often find is that people don't talk about it at all at 13 to 15 month review, because they think, oh, they're just babies still, they're just one, we're not going to talk about toileting, they're far too young. And then what happens is they go back at 27 or 30 months, by which time they're 2.5. And if you're just starting to introduce the topic of toileting, then what happens is actually, oh, okay, we'll start. Yeah, we'll get started. But then we're not back until they're 4 or 5. So actually, if there's no ongoing support and review in that time, then you can see very quickly how that would slip, and how if they had any issues. If you haven't seen your health visitor in over a year, are you really going to pick up the phone and ask them questions? Plus, we're really quite difficult to get hold of because we're out and about all the time. So I think it's kind of clear when you look at it, although the pathway is quite good on paper, there are obviously some reasons as to why it's not perfect, even up here. And I know we are quite lucky in Scotland. Our health visiting pathway and the money that has been put into it is definitely, we were definitely quite lucky compared to other areas of the country. Can I have the next slide, please? So it's not just about the pathway, and I've been really interested reading your comments in the chat around about it, because I think it's interesting to know other people's perceptions of health visitors. And I would just like to say that I was a paediatric nurse. I was really quite lucky going into health visiting because I had a background that revolved around child health and development. But actually, health visitors come from a huge variety of backgrounds. We're all registered nurses, but some might be midwives, or some could be adult nurses and actually not have any direct experience of working with children. To become a health visitor, you have to do a course, and it's 1 to 2 years long. It's a master's level course, but it doesn't actually include any content on healthy bowels and bladders, toilet training, constipation. The focus of the course is very much on child development and on safeguarding and well-being, which I absolutely agree is important. But it does miss out, and it's not just this area, it's things like sleep as well. These things are also things that are lacking from the course. The aspects that you would anticipate a health visitor is all about, actually, they don't often have huge amounts of training in some of these areas. We're really relying on individuals' knowledge in this area. Unless they've gone out and sought the kind of training and are supported to do so, you're often going on people's experience themselves. And if we think about what Juliet said and how practice has changed a lot over the last few decades, so has the information provided to families. And I think I picked up on a couple of people saying that it's really inconsistent and often not accurate, because that training and support really just isn't there. Before I do the poll question, I just wanted to mention a little bit about early years practitioners, because it does vary a bit from area to area, but often in health visiting teams we do have early years practitioners, or maybe some staff nurses working in the team. And the early years practitioners traditionally come from a kind of social care background. Certainly up in Highland there might be variations on practice across the country, but if they do, then again they don't have huge amounts of training and information on this either. Some will come from different backgrounds and obviously may have more, but certainly in Highland, when the services went under the council, then often the early years practitioners were council employees, and and they're the ones who are being targeted with work on toilet training. So we would refer to them to do a kind of targeted piece of work on toilet training, particularly children with additional needs, and then they really, really need that information and training to be able to carry out their role. So just worth mentioning about them as well, because obviously there is a bit of a skill mix in the teams in some areas, but there is still variation. Right, so I'm going to just ask you if you have any idea, as per the guidelines, so this is per the government guidelines, what the recommended maximum caseload number is that an individual health visitor should have. And I'm going to grab a quick drink. Do you think it's 100, 175 or 250? Should hopefully be able to see the answers coming in as they come in. So I can see it's quite an even-ish split at the moment. 175 seems to be the most popular. I'll just give it a couple of minutes. So those who said 250 were absolutely correct. So the guidance is that the maximum should be 250. And I think it's worth mentioning that because I think that it's quite a large amount. And actually, I don't know whether that's the public perception of how busy health visitors are. And in reality, like that's the recommendation. And there is a bit of variation because in areas where there's high deprivation, they do try and there is recommendations that they have those numbers a bit lower. But actually the reality is that because of vacancies and sickness, often caseloads are around about 300, if not more. And this includes families where there are, very vulnerable families. So there's two aspects to a caseload. You have your core families and what we would class as additional families. And there's criteria for that. It's not just made up by the individual. But they would be families that would require additional visits to the pathway and obviously huge amounts of support and signposting. As named person, you would be lead professional, coordinating all the child's plan meetings. And I think it's worth just mentioning that because if no matter how proactive and health visitor you are, if you have a caseload of over 300 children and you're trying to do pathway visits on all of these children, then something's got to fall down that priority list. And often the simple things, unfortunately, like bowels and bladders and sleep, etc., are the areas that do get put to the side. And it's not right, but I think people are only human and they can only do what they can do. So I think it was worth kind of just going through that and just showing just how stretched health visitors are, especially when it comes to maybe providing the support, because I think that it's just in some areas they're really not able to do that. And it will depend on vacancies in areas, because if there's large amounts of vacancies, then they may well have cut out some of the pathway visits. The 4 to 5 year was being kind of dropped for a while because it was classed not as a priority. So if you're seeing variation, I could see that a bit in the chat. If you're seeing a bit of variation in the visits in your area, it might be that the decision has been made to cut some of them out while there are vacancies and sickness within the staffing. So that maybe explains that one a wee bit. Can we go into the next slide, please? So just really to summarise health visitors, I think, we are ideally placed because we do regular visits throughout the early years. We do have opportunity for regular discussion, education and advice, giving advice around bladder and bowel function from babies right up to school age. And we should absolutely be able to identify and manage these issues. And I think all health visitors do want to do that. I think that we really want to do the things that in our heads the job is all about, but there are huge time constraints and competing priorities. There's a varying knowledge and training amongst health visitors. And I do think, going back to that survey that Juliet spoke about with the Kindred Squared, that actually what we need to do is all work together and not see it maybe as the role of one group or the parents or etc. But actually, if we're all working together and we've all got the same key messages, then that's probably the way that we can be most effective. Can we go into the next slide, please? So just for a slight change of topic, I wanted to speak a little bit about Paediatric Continence Scotland. So Paediatric Continence Scotland was founded in 2020 to help children and young people with bowel and bladder problems, their families, and also the professionals who are looking after them. The membership is open to any health or allied professional, because we understand that continence problems in children in childhood right through adolescence are distressing, stigmatizing, and often linked to other physical and mental health problems. So the idea behind Paediatric Continence Scotland is we try and see the child and young person as a whole in order to give them the very best care that we can. The aims of Paediatric Continence Scotland are to provide a supportive network. We hold regular CPD education days, and we lobby against the government for better provision of children's continence services across Scotland. I think we're a really small group, set up of a very small number of professionals, and I just wanted to highlight it. We do have a website as well, and obviously it's something that is is based in Scotland. So please do go and have a little look at the website. It's www.paediatriccontinence.scot.nhs.uk. And a couple of the things that we have been working on is, as you can possibly tell, because I'm a health visitor, I'm quite passionate about health visiting and our role in promoting bowel and bladder health. So as part of Paediatric Continence Scotland, we've been trying to kind of get it mandated that they receive training but are actually able to have it as part of their role, and they are equipped to do so, to talk about bowel and bladder health and also be able to kind of carry out checks and around about that and provide accurate advice and information. And we're really trying to get it into the health visiting pathway kind of officially, so that they do recognise it's been left out, and agree that it should be in the role, but this seems to be quite a long process, so it's being re-evaluated. We're hopeful, we're optimistic that this will change, and I know a couple of the comments were around about doing something similar along the lines of scripts or advice for health visitors through Eric, and I know Juliet's responded to that a little bit. But certainly I think there's a lot of work we could do with health visitors around equipping them with the kind of knowledge and skills they need to take this forward. The other thing Paediatric Continence Scotland was involved in was a review of children's continence services in Scotland in 2022. It seems like it was yesterday, but unfortunately it was 2 years ago now. And we had carried this work out before a few years ago, and it probably won't surprise any of you, but there's such huge variations in services across Scotland, and a lot of areas don't have what we would call that integrated approach. So we should have a service, paediatric bowel and bladder services in our areas that look at kind of integrated services for constipation, nocturnal enuresis, daytime wetting, and soiling, etc. But we don't often have that. There's very mixed services across the country, and we don't have a lot of paediatric services just committed to paediatrics. So often children move from kind of GP right up to paediatricians in the hospital, and there's quite a lot of discrepancies in the pathways, which probably doesn't surprise. It's quite fitting, I guess, with the rest of it. But it's not all negative. Can I have the next slide, please? So there's a really good bit of work that's just been completed by the Western Isles, and they were really, really struggling with providing kind of consistent advice, and they've come up with this document which they've put together with Paediatric Continence Scotland and Bowel and Bladder UK, and it really is a document that is for children and parents. It's really, really good. It'd be worthwhile having a wee look at, but it's also really good for staff as well. It contains lots and lots of information right across toilet training, additional support needs, and bedwetting, and gives lots of kind of helpful advice, tips, etc. And it's quite it's straightforward and it's not complicated, and it's a good easy read, and it's a good example of some local work that's been pulled together that is interesting. And you can also obviously signpost parents to that as well to have a read, because it's kind of written, the language is written that it's appropriate for parents too. And there's also some more work going on in Scotland that's set up to kind of standardise conscience assessments. It's maybe not something that you are involved in as a group, but it's mainly for children where they're being put forward for containment products. They're trying to kind of pull together some documents that make that an equitable practice for children and families. So I can put a link for that document in the chat if that would be useful. Can we go on to the next slide, please? We're nearly there. So I just wanted to have a little kind of try and illustrate through a study just how important it could be, like what a difference it can make if we all work together and everybody has the knowledge and the skills to address and manage these problems. So this is a kind of common scenario that we would have in health visiting. So we've got a baby, and the baby is breastfed by the mum until they go back to work at 9 months old. And at this point, the mum stops breastfeeding and moves the child onto formula milk. Around about the same time as well, the child is obviously being weaned. So they started on solids at 6 months and then moved going through that process from 6 to 9 months. As we see so often, they then stop the formula milk at a year and go on to a follow-on milk. And often at these points, when you change their milk, so from breast milk to formula milk, or from one formula to another formula, or from formula onto cow's milk at a year, then you often see that there is a change in the bowel and bladder habits. But unfortunately, in this case, that happened. The poos became harder, but nobody really spoke about that or spoke to the parents about that. And they just thought, well, on solids now, so poos are a bit harder. Actually, that's way easier to clean up in the nappy. Not so soft, not so messy. This is great. Then the problem with that is that toilet training, when they started that at age 2.5, this child had already learnt that pooing is sore, because they would do the face, they'd strain, they'd pass a poo, but nobody really knew that that was a sore for the child because they weren't able to communicate that, or that they were constipated because they didn't know what constipation was. Nobody had spoken to them about it or indicated that small, hard poos in a child indicates constipation. The problem with that is you start toilet training and the child already knows it's sore, then what they start to do is they start withholding. It's not necessarily conscious, but if you have this cycle of where it's sore, a child will start to hide away. They will try and hold on to their poos, and it's really commonly misconceived because people think that they are like straining to do a poo, but actually what they're doing is really holding it in. So they're tightening all their muscles and holding it in. And they often take themselves away to do that, so families aren't aware. But the health implications going forward can be huge from this. So when you've got a really full bowel, so they often end up constipated from withholding, and you can see the wee picture there of the cycle. So the poo builds up, they become constipated, then it's sore to poo, so they withhold more, and this just goes on and on and on. But what can happen from that is a really, really full bowel can push on your bladder. It means you can't empty your bladder properly. Often that can result in urine infections, and obviously the child can be unwell with those. But you also get this real fear of toilets, and I'm sure someone in the chat will have written about a child who will only poo in a nappy, because it's a really, really, really common scenario that we often see, and it's often associated with constipation initially, or kind of fear and anxiety around about the toilet. And then what can happen is you can get daytime accidents. And my interest and love of all things pee and poo started when I worked in Edinburgh at the Sick Kids and as a urology nurse. And we used to get children coming through, and this would be the picture. They would be having daytime accidents. They were always above 4 years old. Daytime accidents, wetting through the day, wetting through at night, doing that at school, and really things were really, really bad. And when I went into health visiting, I started to understand how they had got from A to B. And actually, it's really much more complicated to undo it all than to start at the beginning and educate and advise from the start. So the next slide is how it should have gone, and hopefully will make a difference. So the alternative journey, and the one we're really striving for, is that health visitors are trained and educated to ask about bowel and bladder patterns at each visit from birth, that parents have an understanding of how bowel and bladder habits change during the first year and how to spot the signs of constipation. And that we follow the Eric's Let's Go Potty approach, where we start sitting them on the potty once they can sit up. So that early introduction. And the other thing is around about introducing a cup and clear fluids when they're weaning. So what happens is they're on milk, they've got their formula milk or their breast milk, we introduce solid food, but we don't really promote drinking clear fluids at this point. We think, oh, they'll get all their drinks from their milk, and we don't actually really promote let's start drinking. And I don't know if anyone was to force you to sit down and eat a meal without a drink. It's not really that pleasant an experience. So what should happen is they should, through the weaning information from health visitors and anyone else that's caring for the child, we should really be advising around about introducing a cup and clear fluids at this time. And that when they get to a year, how much milk they should be going on to, because a really common scenario, and probably one that you see in your settings, is a little one coming in age 2.5, but still with bottles of milk, and they'll be having 4 bottles of milk, 5 bottles of milk, 6 bottles of milk a day, and they get really constipated because it's just too much milk and not enough clear fluids. So if we're monitoring for the signs of constipation, we're giving advice around about what constipation looks like and when the trigger points are. So weaning, toilet training, teething can often result in constipation, and that early year setting support as well. So everybody who's involved in the child are being, having the same kind of advice and that same consistent approach means that early intervention can be given if it's required. And what would this mean? Well, it would mean that we have that gradual acquisition of toilet skills, because we'd be right from the start focusing on bowel and bladder health. We would be starting early, so that preparation phase that Juliet was talking about, going on to that ongoing practice. Parents would be aware where and when to seek advice and support. The child would be used to the potty and the toilet and the bathroom environment, and parents and carers would be in tune with their bowels and bladder patterns, can't speak, and the idea being that we would maintain a nice, soft, regular poo throughout, and we would not have all the issues that we saw previously, which should mean we have toilet training success. So that whole build up right the way from when they're born to toilet training at the right time, hopefully, is what we're aiming for. And actually, I think if it's not overly complicated and it is achievable, but we just need to have everyone working together with the same advice and knowledge. And next slide, please. And that's it. Thank you so much for listening to me. I hope that some of the information was useful to you all, and we look forward to obviously moving on to taking any questions. Thank you.
Thank you so much, Juliet and Suni. That was so informative. I've learned so much, and I can tell by the lovely reactions from the participants that they're the same. And I can tell from all of the chat, lots of chat in the chat box. We've got just over 5 minutes for questions, and Jackie has been going through the chat box to pick some of them up. And I believe that if we don't have time for them all today, that we can maybe perhaps take a note of them and get back to people at a later date. Is that right, Juliet and Suni?
Yeah.
Yep. Great.
Yeah, that's fine.
Fantastic.
I've been trying to answer some as well, put links in against people's things, but I know they sometimes get lost in the chat.
That's lovely. Thank you so much. So I'll just pass over to you, Jackie.
Perfect. I've been marking down, Juliet, when you've been answering, so they don't ask the same question, because folk can trawl through. What I've got here is there an agreed support that health visitors should provide to children in ELC services to help support children to become continent? Is there anything structured that they should be doing? I know it's in the pathway, but is there anything proactive that they should be doing to support children in their peeing and their pooing?
Well, I think I'm probably best placed to answer that one. And I think that unfortunately there is nothing mandated. So there's nothing that says that they have to do it, but specifically around bowel and bladder health, it doesn't say those specific words. But the role of the health visitor is obviously to advise and support children around about all aspects related to health and development in those early years. So it is absolutely within their scope, you know, to be able to do that. So I think, you know, it is a reasonable expectation. And as I said, I think most health visitors really, really want to be able to provide that information. And I know it will be different from area to area as to what kind of services are available, depending on, as I said, on the kind of numbers. But I think it's a reasonable request, absolutely.
Perfect. Any advice for supporting children who are non-verbal, who are deemed non-verbal, difficult communicating around bowel and bladder? Is there something on Eric? I think I read somewhere, Juliet, on the site at one point. You do have stuff.
Yeah, we have lots of information around for children with additional needs, children with sensory issues, for non-verbal, all sorts of things. I'm going to help. I think Suna, you might be better placed to answer this question because you probably know where everything actually is on the website.
Yeah, and it's, yes, there's loads and
So
loads
much
of
stuff,
information,
loads of
so
information.
much. But I think there's a couple of things I was going to say around about that might be really useful, I suppose, is looking at the bit that for that child, that's the challenging bit. And I saw one comment in the chat that was around about communication. That's maybe the one that you're mentioning, but it might be that it's communication for a child, or it might be that, you know, they aren't able to sit on the toilet without balance. So I think it's really working on the area that is specific to that child. It might be that if they are neurodiverse, that actually it's a sensory issue. So the bits that I would direct you to on the website are, if you go to the information and advice section, then under that go to the potty training bit, and there's a bit on potty training children with additional needs. But if you also go to the how we can help you section, then underneath that there's a big section on children with additional needs that has loads of information around about all of those issues. So children with toilet anxiety, the communication. So there's lots and lots of resources around about pictures that can help, social stories. There's tons there. It's probably too much to go into, and I don't want to take up all the time when I know we haven't got much less, but lots and lots of information on the website.
Perfect.
I'm just putting the links in just to
Thank you.
help you as well there.
Juliet, back to the sort of training, one of the questions was, if a group of childminders sort of like become a wee conglomerate, could they apply for multiple licenses, or do you treat them as individuals?
No, if they want to get together. No, if they want to, I mean, in some areas, there are childminder networks. You know, local authority often facilitate those. So in that instance, you would expect that they would be buying them in groups. So yeah, there's not a problem if it's a group of like-minded people coming together. That's a great idea.
Well, there's a Scottish Childminding Association, so it might be wise for maybe Sunny to get in contact with them, because they're a big organisation that a lot of childminders link in with, and that's a big organisation again that might be looking for a deal maybe for their childminders.
Is that the SCMA that I just saw in the chat? Right,
that's
yeah.
Yes. One of the comments that was made was, does using the term potty training exclude the sort of children who are moving on to using the toilet, you know, with the inserts and stuff like that, if we refer to potty training, or is it a wide known term, knowing that it's from getting the children at the nappies sort of thing? That's just a term that's used. Yeah. So or is there another term?
In the training, Brenda says that we use the words potty training, potty learning, toilet training interchangeably. And that's because there will be children of different ages going through this. So, you know, we've put these videos together based on an ideal scenario that, you know, you'll have the child, the baby, the young child in nursery, and you'll be working with them and the family all the way through. But we do appreciate that people will come to this with children at different ages and different stages and with different needs. So I did see in the chat there was somebody said that they don't use potties. Or a few did say they don't use potties, and that might be because they've got toilets and the children go straight to the toilet. Mm-hmm. That's absolutely fine. Just use the terms interchangeably.
Brilliant. You've covered a lot of the stuff around finding access to bedwetting and good books around constipation. A lot of the is there an ideal time or milestone for a child to be looking to be continent? Is there an average that people should be aiming for?
Well, children are most receptive between the ages of 18 months and 2 years. But obviously that's not all children are going to be the same. I mean, there will be some children who can do this when they're younger. I mean, if they used to in the 1960s, children haven't changed that much. But the age 18 to 24 months is what the evidence says is the best time. But obviously, if a child is 2.5 and they've not been near a potty, then, you know, you still work with them. But that would be what we would say would be ideal.
Ideal, but it's okay, like you said, the minute they can get sort of core stability to let them sit in the toilet and get them used to it. A couple other questions is why do you think there's been an increase in childhood constipation? Why is constipation in childhood such an issue now?
There's probably hundreds of reasons for this, isn't there? I think there's loads and loads of reasons. One being that there's been a change in diet. So I think that we eat more processed foods and quick fast foods than years ago. And yeah, there's been a change in how we grow foods as well, and they're produced as well. So I think that's definitely one of the reasons. Unfortunately, I think as well that children don't get as much exercise as they used to. I think that that's definitely one of the reasons too. I think that one of the things is it probably was underreported before. So I think that children, we now know a lot more about it than we used to, or we know more of the signs of constipation than we used to. So I think when we estimate the numbers that we have, so they say 1 in 3 children have or have suffered from constipation, it's probably more than that, but there's still a bit of a stigma associated with it. So I think it was probably underreported before, but I think lots of reasons. Is there any more, Juliet, you would wish to add into that?
I would add to that. It goes back to one of the comments that I made about why toilet training is later, and often that can be a lack of routine and rushing. So actually not having the time to sit on the toilet and, you know, prepare and go. You know, if you're kind of having your breakfast and then rushed out the door and you've not had time to actually sit there and try, and then you know, that can be another reason too.
Again, a lot of the questions are related to health visit, and you covered them, Sonia, about getting the health visitor on board. So again, I think you've kind of covered that. They do have a role to play. So a lot of these questions are in relation to getting the health visitor on board to actually support the potty learning and potty training and go toileting or whatever. There's one final one here, is around, is there any correlation between the health visit and visits and the sort of time frame that children become more continent, like as in you were saying, they start to look at it about age 5. So has there been that correlation, or it's got here as part of the review of the health visit and pathway, is there any correlation between the timeline of visits and toilet training being much later?
So I don't know the results of the reviews of the pathway yet. I'm not sure that they're have been kind of officially released. So I'm not sure entirely on that, but I think that often the visit that's been put to the side if teams are busy or understaffed has been the 4 to 5 year review. It's a difficult one to answer because I think, like I said before, the visits are not ideal for toilet training. So absolutely, it could be part of the reason that we're seeing that, because if you're not getting the advice on it until at least 2.5, then actually families are probably not starting to even think about it until that stage. But that's my kind of presumption of a link between the two, rather than I haven't seen that there's kind of documented evidence from the review of the pathway.
Perfect. Well, I think that's basically all the main ones covered. There's a couple of wee sort of individual specific ones that I don't think we have time to cover just now. Back to you, Lynn. Thank you very much.
Thank you so much. Next slide, please, Jenny. Oh, what can I say? Thank you so much, Juliet and Suni. It's been so informative. I've learned lots. Certainly some of the stats that you shared were very sobering, and that's why the work that you do and all of the resources that you signpost to and you develop are so important. So thank you so much. And everyone, before you go, just one last ask. If you could fill out our evaluation form, you can either scan the QR code or click on the link in the chat. We are a quality improvement team, so we value your feedback and it helps us get better. So thank you so much. And whilst you're just doing that, I'd also like to take this opportunity to thank Jackie and Jenny. There's so much work goes into developing this session and delivering this session, and they work so hard behind the scenes. So thank you both so much for that. Next slide, please. Someone mentioned in the chat that you're keen to capture your learning. So yes, please do capture your learning through the SSSC My Learning app. You can log on there and log your learning from today's session. You can use the QR code for that, but it must be scanned through the My Learning app. So you open the app and you add a new log and click on the QR code, and you're able to log your CPD that way. But don't worry if you've missed the evaluation QR code or that one. We will send out the recording and the slides in a couple of days' time. So last but not least, I would just like to thank all of you for joining us this evening and for your participation. Do take care and enjoy the rest of your evening. Thank you so much. Bye-bye.